Friends, welcome to my workplace at Ranaghat, West Bengal, India. This cataract appears like a posterior polar cataract, and I am going to take all precautions that should be taken in a case of posterior polar cataract. The main incision has been made. This is a side port on the right side of the main incision, and now I am going to stain the anterior capsule with trypan blue dye underneath this air bubble. When we apply the dye underneath an air bubble and stain all the areas of the anterior capsule, the staining is very quick. This is a bit of adrenaline, and now the dye is washed out. So within 15 seconds, the anterior capsule stains nicely. And now the anterior chamber is filled up with a viscoelastic substance. This is 2% hydroxypropyl methyl cellulose. And now one more side port is to be made on the left side of the main incision. The side ports are about 2.5 to 3 clockworks away from the main incision. And now capsulorhexis. With the help of the ureter forceps, the anticapsule is pierced and a capsular tag is raised. This capsular tag is guided all around to get an adequate size to access. This cataract is quite dense. Nuclear sclerosis is about grade 3 plus or grade 4. Because of omniglow, we sometimes can't make out the density of the cataract from the appearance. This is hydrodelineation. I am going into the substance of the nucleus, getting a plane between epinucleus and nucleus and injecting the fluid. My plan is to keep a epinuclear shell to protect the posterior capsule. So hydrodelineation has been done, and now nuclear rotation is not done at all. And now no attempt is made to rotate the nucleus. And now I introduce the tip of the phaco needle. Go, in this case I am going bevel up, remove some superficial lens matter, and now I am going to bury the tip and going through the substance of the nucleus. Submarine job, yes, and a nice crack. And now I don't rotate the nucleus, make another job at 4 o'clock, and this piece of nucleus is removed. Now I turn the handpiece towards 7 o'clock, make another job and make this nuclear piece free and emulsify this nuclear piece. Now I again turn towards 3 o'clock, and this piece of the nucleus comes out of the bag, divide it into 2 pieces and emulsify these pieces. Ultrasonic energy used is 70%, flow rate is 45 ml per minute, vacuum is 450 millimeter of mercury for emulsification of these pieces. The nuclear piece on the right side is also removed. And now a thick shell of epinucleus. So the way I did hydrodelineation worked really. I went into the substance of the lens matter, got a plane between epinucleus and nucleus and injected water, injected BSS, and I have got this thick shell of epinucleus. Now I have come out, I am doing hydro again very gently, only 50% injection on this side very gently inject the fluid, turn, inject BSS on the other side 180 away, and now I use the Simcoe cannula to pull this epinuclear shell towards the center. Hold it here and separate this portion. Turn to left side, hold it at 3 o'clock and pull it. And now I go through the side port, hold the shell at 12 o'clock and pull it, and find a gap between the posterior capsule and the epinuclear shell. Go through this gap, go behind the epinuclear shell and tent it up, lift it up. All these are done very gently, and now I inject visco between posterior capsule and this epinuclear shell. And now I go again in FECO 3 setting to remove this epinuclear shell, where the vacuum is 250 millimeter of mercury, flow rate is 25 ml per minute, and vacuum is set at 50%. Ultrasonic energy is set at 50%. Though we are using only 20% or 10% ultrasonic energy for removal of this epinuclear material. And now we have to lift this epinuclear shell very carefully. We must not go near the posterior capsule and try to hold it. Yes, it has come out and the posterior capsule is intact. Probably this was a posterior subcapsular cataract, but whenever there is a thick patch with onion hole appearance or without onion hole appearance, a thick patch at the center of the posterior capsule, we must take all the precautions which we should take in a case of posterior polar cataract. At least we should remove the nucleus before PC rent occurs. If PC rent occurs during removal of cortex or epinuclear shell, through the rent some soft lens matter will drop into the vitreous cavity, which can be easily removed by a vitrectomy cutter. But if the whole nucleus drops or if some hard nuclear piece drops, then we have to use a fragmentum for removal of the epinuclear material, and that has to be done by expert hands. The surgery becomes very much complicated. But if we can manage with the cutter itself, the surgery remains manageable easily. And now, in this case, I selected a multi-piece intraocular lens. This is sensor multi-piece intraocular lens. Let us see how to load this lens in the cartridge. I take the lens, hold the lens and go from behind, push it. At this position, it is tapped at the center and the leading haptic goes into the cartridge and the plunger is placed and it goes in. And now the main wound has been enlarged to about 3 millimeter, so that this lens can be easily delivered in the bag, so that a portion of the cartridge goes into the anterior chamber. And now I turn the cartridge clockwise. Yes, I turn it clockwise and the haptic comes out parallel to the posterior capsule. As the haptic goes to the equator, I turn the cartridge anti-clockwise and the lens is delivered, optic is delivered parallel to the posterior capsule. And now I hold the haptic with the McPherson's forceps and place this haptic in the capsular bag. And now the lens is in the capsular bag, nicely centered. So this is the trick. And this lens is very good, no glistening over the ears. I have no financial interest, but what is good and what is true, we should openly discuss. Now, the visco that was filling up the anterior chamber is removed. I take the bimanual irrigation aspiration. I use the irrigation first, go behind the intraocular lens and irrigate fluid between the posterior capsule and the intraocular lens. Again, come in the anterior chamber, irrigate fluid all around so that all the visco from the anterior chamber angle comes out. Now, irrigation and aspiration is used for some time. We must dedicate this 1.5 minutes time for removal of the visco. Otherwise, there will be visco-induced raised intraocular pressure next day and for a few days, and the patient will not be happy. The side ports are closed by hydrating corneal stroma on either side of these stab wounds. And at the last, a final lavage of the anterior chamber is done. This is a 23G Simcoe. The anterior chamber is nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.